Hi, welcome to this learning module on the rehabilitation therapy services you will encounter on the inpatient floors, Zayed 3 West in the NCCU, Zayed 12 East, and Zayed 12 West. We are first going to review the role of physical therapy in the acute care setting. We're going to review what our evaluation and intervention may look like in the acute care setting. We'll go over the common indications and contraindications for ordering a physical therapy consult, and then how to go about doing that within the Johns Hopkins electronic medical records system. Physical therapists are experts in analyzing mobility and motion. We will thoroughly examine a patient's physical deficits, such as strength, tone, balance, or gait, and how that impacts their roles in life, what activities are limited because of these deficits, and how, overall, it's impacting their functional mobility and independence. The PT evaluates the functional needs of the patient. This will encompass determining the patient's functional baseline, where they were before the onset of their illness or before they underwent surgery, and the current variance from that baseline, also known as their functional variance. Then, the PT establishes a therapy plan of care for and with the patient to assure that the patient is as active and mobile throughout their admission as best as possible. Based upon their needs, we will follow up with the patient throughout their hospital stay. We determine a patient's frequency of follow-up based on their functional variance. Those that are further away from their baseline will be scheduled at a higher frequency than those that are just a little bit away from their baseline. We also collaborate with the healthcare team to recommend and prepare the patient for the next level of care, be it an inpatient rehab facility, home with home therapy services, or outpatient follow-up. And now just for a brief glimpse into what a typical PT evaluation includes. Before walking in the room, of course, we do a thorough chart review. We're looking at the medical team's notes, any other consulting services. We look at the patient's lab values and how that may affect their response to our intervention of getting up and moving or exercise. We take a look at their medications, checking their orders, and any other pertinent imaging in order to adjust our approach as needed. Once in the room, we do a detailed subjective exam, gathering information on the patient's prior level of function, their current level of function, and deficits they feel that are impacting them the most and preventing them from returning to their normal roles in life. We will help them develop personalized short and long-term goals for their rehabilitation. Our physical exam is your typical neuro exam, looking at your strength, range of motion, tone, sensation, proprioception, cranial nerves, vestibular function. We will do specific balance objective measures and gait objective measures, as well as performing a thorough gait analysis for those patients that are ambulatory. We also take a look at the patient's cardiopulmonary function and how that might be impacting their mobility, their tolerance to activity especially, and we will take a look at their skin integrity. We will then analyze functionally how the patient is performing basic activities, starting with just the simple act of getting in and out of bed or transferring from the bed to the chair. As patients progress and get stronger, we will definitely look a little bit more closely at their gait and balance and generalized strength. After this examination, we develop a rehabilitation plan of care and discharge recommendation. After our evaluation is complete and we're following up with the patients, we choose their PT interventions based on their highest need. What do they need the most in order to get better? So some of this might be balance training and gait training, which we'll get into on the next slide. We also prescribe therapeutic exercise, targeted strengthening, and flexibility exercises to help improve their function. We might develop activity modifications, and so if they have certain deficits, that weakness, say, that prevents them from doing a normal transfer, we'll teach them other techniques, again, to help maintain as much independence as possible. We will train them on assistive equipment such as canes and walkers and crutches. We also will train with different orthotics or bracing, how to don and doff them, and collaborate with an orthotist, prosthetist in order to meet the needs of that patient. We also will do vestibular rehab in those patients with central or peripheral vestibular deficits. These patients benefit from PT, both in the acute care setting as well as most likely outpatient follow-up. And we also share a role with respiratory therapy and airway clearance. Although not extremely typical on the neurological service, but We also will help with airway clearance patients that have a physical deficit in addition. So things like chest PT with percussion and vibration or other breathing exercises to really help improve their pulmonary toilet. Once we are able to determine the underlying physical constraint that is causing a patient to have impaired balance and gait, we can address these likely through treatment interventions. We determine when to begin these interventions based on the patient's medical stability. As you can see from this picture, support like ventilators, LVADs, most lines and drains don't necessarily contraindicate mobility. We can begin these interventions during a patient's ICU stay and hopefully as soon as possible. Once a patient is medically appropriate, we can target interventions that work to normalize a patient's gait pattern, thus improving their gait efficiency, safety, and independence. We may utilize assisted devices such as various walkers, canes, braces, and body weight support systems that can maximize this patient's ability. Balance retraining exercises are designed to make a person steadier during walking and standing through improvements in coordination of muscle response and organization of sensory information, such as their vision, their balance, their proprioception, and sensation. Early mobilization has been shown to decrease both ICU and hospital lengths of stay and improve patient outcomes and overall survivorship, so don't underestimate your patient's physical abilities. Discuss with a therapist whether the patient is appropriate for therapy early on in their hospital stay. Another specialty of physical therapy, especially with the neurological population, is vestibular physical therapy. The program is designed to achieve a decreased dizziness and visual symptoms, improve their balance and walking functions, and generally increase activity levels. Vestibular physical therapy may include exercises for coordinating eye and head movements, stimulating the symptoms of dizziness in order to desensitize the vestibular system, improve balance and walking ability, and improve fitness and endurance. And the exercises vary depending on the type of inner ear disorder and associated symptoms. We are trained to treat conditions such as BPPV, central vestibular lesions, generalized vestibular hypofunction, acoustic neuromas, semicircular canal dehiscence, and more. As I mentioned before, when examining a patient, PTs consider all the body systems, including the cardiopulmonary system. When consulting physical therapy and POE, you may notice a checkbox for airway clearance under special instructions. We work in tandem with respiratory therapy when patients have a compromised pulmonary system that is impairing their function. The cardiopulmonary system plays an integral role in postural control, and PTs are able to effectively pair ventilatory strategies with specific movements in order to establish the pulmonary system as an asset rather than a liability for their patients, regardless of whether their original diagnosis was physiological or physical. We utilize techniques such as manual percussion, positive expiratory pressure therapy such as the acapella, which is the green and blue devices you see on the left of the screen, in order to help patients mobilize pulmonary secretions. We'll also address physical constraints on overall trunk and chest movements that may be inhibiting efficient respiratory function. At Hopkins, it is a policy that if a patient requires both airway clearance and has mobility limitations, the chest PT treatments will be split between physical therapy and respiratory therapy. If the patient has no mobility restrictions and only pulmonary deficits, then respiratory therapy should be the only therapy consulted. For example, a patient with pneumonia and is ambulating independently, no strength deficits, is independent with basic ADLs, respiratory therapy should be consulted. A patient who has pneumonia and has had a stroke, leaving them with hemiparesis, both PT and RT should be consulted. PT will incorporate both airway clearance activities and functional mobility training, or our usual care for patients in this situation. Another small subset of physical therapy that you'll see pretty much only in the acute care or inpatient rehab setting is called coma stimulation. Patients who are in altered states of consciousness, such as a coma or a minimally conscious state, may still benefit from skilled PT. However, patients who are in a medically induced coma are not appropriate for therapy. At a minimum, patients who react inconsistently and non-purposefully to stimuli in a non-specific manner, such as eye blinking, Changes in a breathing rate or heart rate, gross body movements, and vocalizations are or may be appropriate for physical therapy. They do not have to be following commands. Coma stimulation is an intervention that is accomplished by exposing the patient to graded sensory stimulation designed to elicit purposeful, goal-directed responses. Kinesthetic, tactile, auditory, and visual stimuli is used during this intervention. Utilizing the JFK Coma Recovery Scale, a standardized instrument for grading progress in these patients, therapists work with the individual to maximize his or her physical, emotional, and functional potential. We will try to incorporate family and or a caregiver as part of the treatment plan here. We want to educate them so that they become an active member in the coma stimulation team, as this is something that should be occurring throughout the day, not just during a therapy session. If you have any questions on whether a low-level patient of yours is appropriate for therapy, please ask a therapist on the floor. So how do you get your patient physical therapy? So we are a consult service. Therefore, in order for us to evaluate and treat a patient in the hospital setting, we must receive a physical therapy order. In addition, in order for us to consult on a patient, there must be an activity order that is active in POE. For the most part, this order will be, quote-unquote, activity is tolerated. If the patient has weight-bearing precautions, these must be ordered in tandem with the activity order. There are specialists that specialize in wound care. They are a separate team than your therapist that you will normally see up on the floor. They particularly see patients in need of pulse lavage and selective debridement of deep wounds. There is a separate consult for quote-unquote regular physical therapy and wound care PT. So double check and make sure that you're ordering the correct physical therapist. We check for new orders at 7:30 each day in the morning and assign patients to therapists at this time. If a new PT order is placed after that time and the patient's discharge is pending our evaluation, we ask that you please page the neurotherapy consult pager and ping. It's extension 30680 with this information so that we can cover the patient for the day. This is also if you have any questions regarding if a patient is being seen that day, or if you need to know how they're progressing, or you need to relay any need to know information and don't know who the therapist is assigned to that patient. Please page the consult pager, and this consult pager is also the same pager for occupational therapy and speech therapy. So now that you know a little bit more about our role and how to consult PT, who are the appropriate patients that need our services? Patients, basically, who are not at their functional baseline, they're not achieving their optimal independence with functional mobility due to physical deficits either caused by a new disease or an exacerbation of a chronic condition, are most likely appropriate for therapy. Again, we also have wound care PT, and so that might be for more of your wound management. Most likely you'll hear that they need that type of consult from the wound nurse. So who are those patients who don't need us, who might be more of an inappropriate consult? Patients, if there's no change in their functional baseline, whether they're totally independent or whether they're the opposite and totally bedbound and have been that way for months to years with not really a great prognosis of improving their strength, these patients might not be appropriate. Sometimes patients are admitted with profound physical deficits, but they are not new and not anticipated to change after treatment for their admitted condition. Patients who are hemodynamically unstable, have unstable fractures, especially in their spine, those who are medically sedated, are most likely not appropriate for PT until those conditions are resolved. And lastly, I just want to touch on what is not skilled physical therapy. So in order for a PT to continue to treat a patient in any setting, there has to be a skilled need, an intervention that can only be provided by a physical therapist. So being asked to walk with a patient when they are independent just for the pure sake of walking isn't necessarily a skilled need. Obtaining an ambulatory oxygen saturation reading, not a skilled need. And getting a patient out of bed to the chair doesn't necessarily fall only on the PT. If they have issues with this, we're obviously going to be working on that during our sessions. But when patients aren't in physical therapy, We work with the nursing staff to engage patients in a personalized activity and mobility program to optimize their function during the hospital stay. During care coordination rounds, we discuss these patients' mobility status, what are the barriers, and how best the nursing staff can assist patients with out-of-bed activities throughout the day.